Listen now to a talk I had with Dr. Kristen Patton, Associate Professor of Medicine at the University of Washington in Seattle. We cover indications for pacing, making sense of the guidelines. Kristen, thanks for being here at Accel, and perhaps you could give us kind of an overview of your approach to patients for pacing and ICD therapy.
Thank you very much for having me. I think this is a really interesting time in device therapy for numerous reasons. And I think the thing that's most important for people to be aware of right now are the recent guidelines updates for biventricular pacing that were published in 2012. More and more as we investigate patients who benefit from biventricular pacing, we find that the benefit is not limited, but is certainly most impressive in patients who have a really wide QRS of greater than 150 milliseconds, and in patients who have a true left bundle as opposed to an intraventricular conduction delay or a right bundle branch block. And you can see the results of those studies really made a difference with respect to who now is a class 1 recommendation for biventricular pacing, which is the patients with a wide left bundle branch block, and that patients who have a narrower QRS complex, as well as patients who have a non-left bundle, if they have class 2 heart failure, those are now a class 3 indication, meaning that we should not be putting biventricular devices in those patients. In addition, thanks to the MADET CRT trial, as well as several other trials, the biventricular pacing indications have really been expanded towards patients with more mild heart failure. So class 2 heart failure in both the ischemic and non-ischemic population. And it's now a class 2A indication for patients with class 1 heart failure who have ischemic heart disease.
We're talking heart failure patients now, and I think you're right. I mean, the very interesting data that just has come out is that IV pacing in a narrow QRS complex is actually detrimental in many cases. So that, I think, is an important shift to class 3 recommendation.
That is true. There have been numerous studies over the last few years, particularly recently, that show that not only is biventricular pacing ineffective, but there's a signal that it might actually be harmful to patients.
Right. I think that's a relatively important piece of information for dealing with patients with narrow QRS heart failure. Let's talk about the patient who needs a pacemaker because of conduction abnormalities rather than, let's say, trying to improve left ventricular function. If you're going to treat a patient with a pacer now who has a significant serious bradycardia or conduction defect, let's say a 45-year-old person who wants to exercise or work every day, how do you make your decision on choices for that?
I think there's some really interesting new data from the BLOCK-HF trial that was published last year in the New England Journal. And in that trial, patients who had distal conduction disease and required right ventricular pacing were randomized to either a conventional dual chamber pacemaker versus biventricular pacing. And these patients had ejection fractions between 35 and 50%. So they weren't the normal QRS population that you're talking about. And BLOCK-HF was a positive trial with a combined endpoint of reduction in left ventricular end systolic volume index, as well as hospitalizations for heart failure and overall mortality and cardiovascular mortality. So the endpoint was met less often in the patients who had biventricular pacing in that group, but the outcome was really driven by the reduction in LVESVI.
Okay, so again, if there was a reduction in systolic volume index, that came from the BIV approach to the resynchronization, I guess, more
exactly.
than anything else. Okay. We've heard many times over that single lead pacing can lead to left ventricular dysfunction in a normal ventricle. Maybe you could tell us a little bit how you deal with the selection for those patients.
Yeah, I think that's a really interesting question. We know that RV pacing can be deleterious, particularly in the heart failure population. And we know that patients who have atrial fibrillation and who require a lot of RV pacing may have a benefit to biventricular pacing over RV pacing alone in the setting of undergoing an AV nodal ablation procedure, for example. But we also know from since 1960s we've been RV pacing people, we know that patients who have a normal ventricle are relatively protected from this problem. So you do have to be careful in terms of your thinking. The negatives of a biventricular pacemaker system are both that the device will last a shorter period of time, as well as the extra complications of having a third lead. And we all know that putting in a left ventricular lead in some patients is not always so straightforward. Although overall as a group, I think we get better and better at it all the time.
Okay, I think that's helpful information. So a patient with a normal ventricle still tolerates a single RV lead, obviously an atrial lead and a ventricular lead, but there's not a lot of concern about LV dysfunction in that patient. Patient with some compromise of left ventricular function, probably the best choice would be to attempt to get a BIV system in place if you can, because it will do two things. One, it'll help resynchronize, but it'll also help to prevent deterioration of ventricular
I think that's
function.
possible. I think that the BLOCK-HF data are interesting in that light. I think it'll be very interesting to see what the FDA decides about the BLOCK-HF indication, about whether that's approved or not.
Okay, so it's still not at the FDA level. Okay, because we have these kind of decisions all the time in managing patients with either with normal or without normal LV function. And again, so many of our patients now have decreased LV function to some degree that I think the pacing has to be considered in that light.
It's true. And it's always a struggle. And you mentioned particularly a young patient. And we have some young patients who have a dual chamber pacemaker and do well for years. And we have some patients whose EFs become compromised over time. And in those patients, very often they respond beautifully to an upgrade to a biventricular system. The other point that I wanted to make that's a completely side issue to the choice of devices is that you mentioned a 45-year-old patient with distal conduction disease, is that often people don't necessarily, when they see symptomatic distal conduction disease in a young person, think about alternative explanations for why the patient has this disease. And I think that cardiac sarcoid is very often underlooked, and it's something that you have to be thinking about with respect to your investigation, because it would require something like a cardiac MRI or a PET scan. And since that disease has other implications for the patient and management in young patients with unexplained heart block, I think that sort of evaluation is extremely important.
Okay, and where I live, we worry about Lyme disease as well once in a while. Same thing. So think about some of the rare diagnoses sometimes when it's heart block in a younger person. So let me ask you another provocative question. I do a lot of work in diving, and I guess you have divers in Seattle, I'm sure.
Yeah.
And every now and then I get a question about, I have to have a pacemaker and I want to continue my recreational diving. Is it okay? So there are some literature on pacer responses to pressure, and I understand most of the companies test them at various pressures to be able to tell people they can fly or be exposed to pressure. Any comments from you on that?
It's exactly true. And what I usually do when I have a diver who needs a device, whether it's a pacemaker or a defibrillator, is I talk to the individual companies and I find out to what level they've been assessed, and I pick the one that seems the best. It is true that they all tend to be limited to around 50 atmospheres, so it's not that very intense diving can be safe or not.
Yeah, so being a diving person, I would say the 50 atmospheres is too much. It's 5 atmospheres. I just want to clarify that for the listeners.
Thank you. I appreciate it.
But I think it's important because I've had a number of people come to me who had pacemakers that were not pressure tested, and they were very upset about that. So I think it's something that if you have a person, a younger person particularly, who's going to be exposed to some kind of pressure environment, whether it's altitude or diving, that they understand that the pacemaker is tested for that pressure level. So
it's an incredibly interesting area that has come up a lot in this conference, the concept of shared decision making and how to really educate people about devices. And I think one of the things that's so complex about this area is that not only do you have to go through a conversation with a patient about why a particular device is indicated for them and what are the risks and benefits acutely of the procedure, but there are so many complex issues with respect to what it's like to live with a device. And those issues are really different on a patient base. Some patients weld, some patients dive, some patients work on their cars, and some patients really need to know about things like EMI, electromagnetic interference, and how that's going to affect what they do. And some patients don't need to know all that. So you really have to get to know people, not just what they value, but also what they do and what they do for fun.
I agree with that. I think there are occupations and there are recreational exposures that are affected by pacing. And I think it's a really fascinating area. Number one, we're seeing more and more devices being used for therapy, and this shared decision-making issue is very important. Information in both directions so that the proper choice of the proper device is made that works well both for the electrophysiologist and for the patient in their lifestyle. So thanks again for being here.
Thanks very much for having me.